All right. Thank you so much for coming today. Thank you very, very much. Anne is an epidemiologist, and she specializes in mobility for older people.
Sugar.
No, that's okay. It's a very fancy keyboard, fancier than I'm used to. So, good morning. I'm happy to be here. I'm from the Centers for Disease Control and Prevention, and I know that most folks, I don't know what, think of Ebola or something like that when they think about the Centers for Disease Control and Prevention. So I'm going to give you a slide on CDC and the Injury Center, which is one of the centers in Centers for Disease Control. The public health approach to road safety and prevention, just kind of orient you to how my path and public health gets us to where we are in this room, who our older adults are, and how mobility relates to health, which I think is actually even what you asked me to talk about. So I'm compliant. Okay, Centers for Disease Control and Prevention, nation's leading public health agency, headquartered in Atlanta. More than 12,000 employees, actually it's probably a little higher than that, with field staff in all states, DC, Guam, Puerto Rico, U.S. Virgin Islands, where I'd really like to go for a program. I think we need an ITN Virgin Islands, and it'd be awesome. And 120 countries. Okay, so within the centers, there's a National Center for Injury Prevention and Control, right, which kind of has two paths. One are unintentional injuries, which are an obtuse way of saying accidents, but nobody likes to use the word accidents, right, because it kind of implies something that you can't deal with. So we say unintentional injuries, and nobody knows what we mean. So I'm going to say accidents. In my group, older adult falls, motor vehicle crashes, drug overdoses, traumatic brain injury, drowning prevention is what I'm going to talk about later in the week somewhere else. And our violence path, child abuse, neglect, suicide, intimate partner violence, you see all the public health injury issues, and they're all preventable, which is what we like to hit people hard with that message. Okay, narrowing in on transportation, right? Here are the priority areas that we have now in our transportation group. Restraints in belts and seats. We have rural tribal projects. Impaired driving was mostly alcohol, and now it's alcohol and drugs. Data linkage is about getting health and crash information together. And then what we're going to talk about today is older adult mobility. So from a CDC lens, we use this public health approach. So go in a circle, right? When we come at a problem, that actually could be injury or Ebola or vaccinations or asthma, right? You ask yourself, what's the problem? You figure that out. Why did it happen? What works to help? And then how do you do it, right? And so this little feedback loop is what we go through all the time. And we do that in transportation and older adult mobility too. Traditionally, right, when you think of public health and it's the injury center, so you'd think in a traditional way, how many people are killed, how many people are injured, hospitalized, how many people go to the emergency department, and that's how you kind of measure how big your problem is and what your burden is. But in this case, I want to say that what happens when we broaden our thought process into more than just preventing death and injury, right? So if our mission is to reduce injury and death due to motor vehicle crashes and promote safe travel, we're going to focus on promoting safe travel right now. Okay, and we're going to do it with older adult mobility, and if we take that lens, the lens away from deaths and injuries and the lens in promoting safe travel, right, in older adult mobility, I'm just going to talk a little bit about our older population, right? So for the first time in our history, the U.S. population aged 65 and older topped 50 million. And I wrote myself a note so that I would remember to say that's more than the population of 25 states combined. And we're living longer, right? So those reaching age 65 today will live on average, another 19 years. And as you said, I think most of us are actually going to outlive our ability to drive safely. And in living arrangements, I wrote down a couple more stats, and you'll have to forgive me. I am an epidemiologist, so I love numbers. And I know they're too overwhelming on a slide, and so what do? I take them off the slide, but then I make you listen to them because I put them in my notes. So in this one, it's nearly half of all women age 75 and above live alone, right? That's pretty staggering. If you go back to 65 and think about that population, 14 million live alone, 1 in 3 women and 1 in 5 men. Why are living arrangements important, right? If you're living alone, you don't have anybody else to drive you, right? So you need alternative transportation like ITN. Oh, and this one, I love this one too. Okay, so this is people 65 and older as a percentage of your state's population. And so what does it show you, right? The gold and the blue are states that have higher proportions of their whole population are older, elderly. But even if you're that yellow or purple, I mean, when I think of California, okay, maybe its proportion of the population that's older isn't as high as somewhere like Florida, but it's so darn big and it has so many people that there are a lot of elderly folks in California and a lot of rural areas. Okay, so let me switch gears. We talked about older adults and just talk about mobility a bit and define it, right? So in our plain language thinking, we say mobility is being able to safely and reliably go where you want to go, when you want to go, and how you want to get there. And the problems that we have with aging are declines in our mobility, right? So our mobility may decrease as we age due to physical changes, increased chronic conditions, right? Like Alzheimer's disease, like heart disease, like COPD. These things are going to affect your mobility. And then increased medicine use too. Think about the medicines that probably your parents take that might make them dizzy, that might make them sleepy, just not able to get around as well as they used to. And then think about how many medicines they're taking. I think on a bad day, my husband will come down and say, I just took 9 pills in the morning, right? It's staggering how many medicines we take. The problem with decreased mobility, aside from your physical health issues, are that you have reductions in health and you get social isolation. All bad things. So, I have notes to myself for this one too. So, research looking at non-drivers compared to drivers. I wrote this down because I love data and I wanted to make sure I told you the right thing. Okay, doing studies. Non-drivers compared to drivers. Non-drivers 4 to 6 times more likely to die over 3 years. Another study, 68% higher risk of mortality over 5 years, non-drivers compared to drivers. Non-drivers 5 times as likely to enter a long-term care facility over 8 years. And what I wanted to make sure that I told you is that when they're looking at this statistically, they're already taking into account how old you are, if you're male or female, what your health condition is, right? That's already adjusted for, and you get these differences. Combining results from 5 studies on depression found that non-drivers compared with drivers twice as likely to have depressive symptoms. And I was laying in bed this morning thinking, is it important that it's depressive symptoms versus a formal diagnosis of depression? And I decided it wasn't. If you have the symptoms, this is a problem.
This is your life.
Exactly right, whether you have a formal diagnosis or not. So I think that, you know, as a researcher and a scientist, that's kind of an epiphany for me, right? Because I'm always wanting the accurate, precise diagnosis. Maybe it doesn't matter. Non-drivers compared with drivers had greater declines in social engagement over time and greater declines in productive engagement, like work and volunteering. And this next one was one I was really struck by. Non-drivers compared with drivers had a reduction in the number of friends and a greater decline in out-of-home activity, like shopping or going to a movie over 5 years. So the things that make our life rich. So Gwen Bergen, who's a colleague of mine and has worked with Catherine too, we're working on a little tool that people can use to think about what happens when I can no longer drive. So this is what they did. They asked 1,000 people, what is the first thing that comes to mind when you think about challenges you might face in getting to the places you need to go as you get older? Simple enough. Asking 1,000 people, you should get pretty good data. What proportion do you think said none? I don't know. Truly.
95%.
No, actually, only 10%. But still, I was stunned, right? If somebody asked me that, I would at least have one thing that I was thinking about. But let me give you this one. So I couldn't help myself. I had to put in a big old data slide. But driving was the #1 answer that people had if they had an answer. Your physical changes, alternative transportation, health, but it is striking to me that driving was #1. And I think I just have 2 more slides, so we'll make up some time. Older adults' biggest concerns about future mobility: driving, your physical ability to get around, and alternative transportation. The other thing that I was interested in is when they gave older adults material about thinking through your mobility changes and what you might do, they actually did start thinking about their mobility, about protecting their mobility, and the confidence that they knew how to do that. And so I think that's really important here, because if you message alternatives to people, they can start thinking about it. If they know they have an alternative when they're not confident about driving, but they see no options, right? That's the path we don't want to go down. If you have an alternative, it makes all the difference in the world.
That was my hypothesis.
And it does. And so, there's one hurdle about getting people to think about it. And so what we were trying to do was get people, say, 65 to 75 right before they had to start thinking about it, and just approach the subject softly. Because nobody wants to talk about when they can't drive anymore. And I think it was interesting that 1/3 of your folks are still driving, right? So in this transition period, which I think is really important, how do you work folks through that? And I think that's gently, right? So maybe they still can drive here or there a bit, but then they get comfortable with an alternative so that when they really should be not on the road themselves driving, they have something.
And it's their free choice, and free choice is everything to people of all ages, of all ethnicities, of all genders.
Absolutely.
Free choice is where freedom lives.
And so we say, plan now to keep your independence later, right? So plan. And we say, you know how people think about planning for their retirement financially? Start thinking about planning for your mobility needs. A soft way to start thinking about it.
And one of the things that we learned with ITN is that it is much easier to give than it is to receive. And so if you promote volunteerism, one of the questions we ask the volunteers is, has your driving other people made any difference in how you think about mobility for yourself? Guess what, right? Makes a huge difference. Thank you.
You're welcome.
Thank you very much.